Hello, my name is Stephanie Tsonis and I was the appointed Ocular Oncology Clinical Liaison, and I'll be presenting about the Telehealth and Cancer Services project at the Royal Victorian Eye and Ear Hospital. This presentation will share how the project was developed, implemented, and also the impact and benefits of our service delivery and patients. And we'll also share the lessons learned and what telehealth means for the future direction of our services. The Eye and Ear has over 60 different specialist clinics and also provides a 24-hour emergency service. Typically, the Eye and Ear cares for around 220,000 patients each year, and in 2020, COVID-19 did impact these numbers. However, we still managed to see 170,000 patients, including over 110,000 outpatients and more than 40,000 emergency attendances. The telehealth project was implemented in the Ocular Oncology Clinic, and this is a specialist clinic that delivers clinical care to patients with intraocular and periocular tumours. And approximately 85 of these patients have a primary diagnosis of ocular melanoma, and the remainder of the cohort patients presenting ocular tumours, including conjunctival tumours, iris tumours, or orbital and lid tumours. And the clinic also reviews patients who have a suspicious choroidal naevus, and it is this cohort of patients that were the focus of the telehealth project. So a choroidal naevus is a benign pigmented area at the back of the eye, also known as a freckle, and it's usually an incidental finding on routine eye exam, as they are often asymptomatic. And once they are detected, a choroidal naevus should be monitored, as there is a risk that it can transform into a choroidal melanoma. And although the risk is low, with 1 in approximately 8,500 patients, it is still a cohort who needs surveillance. And we thought this cohort of patients would be suitable to trial a video telehealth pathway. In terms of the telehealth journey at the Eye and Ear, it's quite well known what the benefits of telehealth are, and particularly the use of video telehealth is an opportunity for patient-centered care by taking the consultation to the patient, saving them time and effort of travelling and waiting for appointments without diminishing their care. So the Eye and Ear is committed to utilisation of telehealth, and it's part of the key action of our strategy, which included the development of the Telehealth Action Plan 2020-2021, aiming to develop pathways for appropriate patient groups where telehealth is the default appointment mode and face-to-face appointments are by exception. So broadly speaking, telehealth appointments are not always appropriate for eye and ear patients, and the uptick has been slow, and this is due to a number of barriers. Firstly, the limited availability to have a clear view of the eye assessment via video, as usually the quality is device dependent, and this isn't always accessible. And secondly, the greatest barrier is the nature of the diagnostic eye tests and the dependability on these results for clinical decision making. So at the Eye and Ear prior to COVID, telehealth has only been used for post-op patients, and during COVID, a significant number of review patients took up telehealth consultations. However, the majority were conducted over phone rather than video. And currently, on average, only 9% of our telehealth consultations are a video call, and this is something we are trying to improve. What we developed for the Ocular Oncology Clinic was a hybrid telehealth model. And to give you an idea of the patient pathway in the Ocular Oncology Clinic, so looking at the box on the left-hand side is the existing pathway, and all patients had to attend face-to-face. And during their appointment, they had a physical interaction with 3 different health professionals, and they also attended 3 different parts of the hospital. So there's significant movement in different areas. And on average, their time at the hospital would be an average of 27 minutes per appointment. So when initially planning the project, the focus was on testing a pathway for new oncology patients referred for choroidal naevus. However, due to the inability for the hospital at this time to receive electronic images by external referrals, the focus of the project was shifted to test the telehealth pathway on overdue review appointments, patients who had choroidal naevus, and so as such, the hybrid telehealth model was developed. So the idea of the hybrid model involved carefully selecting patients according to a triage criteria to attend the Eye and Ear in person. to complete all the diagnostic imaging requirements. And this occurred 1 week prior to their booked telehealth consultation. So when they attended face-to-face, they only interacted with one health professional and in one area of the hospital. And this was also important to support social distancing measures. And it was also critical that all the diagnostic imaging that was performed was to an ability that enabled comparison to identical imaging from previous visits, and this could facilitate safe clinical decision-making. 1 week later, the results would then be reviewed by the ophthalmologist, and the video telehealth consultation would take place, and the results will be shared with the patient. So the objectives of this approach were to determine the feasibility of conducting an ocular oncology review appointment via video telehealth, and it was also to improve the patient experience by reducing the amount of time patients attended face-to-face appointments. And we also wanted to prevent compromised clinical outcomes if choroidal naevus progression were left undetected due to delayed follow-up and access. We also were trying to aim to reduce the number of review patients attending in a face-to-face capacity and to improve access for more urgent cases that do require tertiary face-to-face care. And we also were aiming to optimise confidence and capabilities of clinicians using telehealth. So in terms of the implementation, the steps to develop and implement this workflow included significant consultation with the head of unit, and this was quite critical to inform all areas of project and to ensure everyone was on board. So this involved fortnightly meetings to ensure open discussion, engagement and partnership. And it was critical, as I said, to ensure buy-in and to listen to their concerns and to support delivery of the project, particularly in a short time frame. So the patient selection process required a triage criteria to identify suitable patients from the review waiting list, and a waiting list audit and medical review was completed to identify overdue patients with a choroidal naevus diagnosis. This was required because there is no documented diagnosis attached to a patient waiting list. So we're unaware of the patients who are on the waiting list, what their actual diagnosis is. In a total, 123 patient records were reviewed, and of the reviewed patients with a choroidal naevus diagnosis, 52% were suitable for the hybrid telehealth pathway. Clerical staff offering appointments also documented the outcomes, particularly noting any reasons that the patients declined the telehealth appointment. And in terms of evaluating the pathway, I was present as a telehealth super user during the telehealth consultation, and that really enabled to facilitate the process, including setting up the laptop and connecting with the patient and just being there to troubleshoot any issues. I also sought doctor engagement and feedback at each session to improve the process, and a planned study act approach was undertaken to support optimal outcomes. And to obtain feedback, a pre and post implementation clinician survey was completed, and a patient experience survey was also developed. So what was the impact? So regarding patient suitability, as I mentioned, 52% of the review patients on the waiting list with a diagnosis of choroidal naevus were suitable for telehealth, and 65% of these patients accepted these appointments. And of the patients who did accept the appointments, there was 93% attendance rate, so that was quite good. Over a 6-week period, 12 patients were seen by the hybrid video telehealth pathway, and telehealth utilisation in the Ocular Oncology Clinic went from 0% to 13%. So that was a good improvement. However, unfortunately, not all the consultations occurred with video. Only 42% were with video, and the remaining 58% were via phone. And this was due to 30% of patients experiencing difficulties to connect, and the consultation was converted to phone. The remainder of patients who opted for a phone review did not have access to a smartphone technology, and also they didn't feel they had the confidence to use it. Regarding the feasibility of conducting an ocular oncology review via telehealth, there was sound clinical decision-making was possible based on the diagnostic images, so all the information that the doctor needed that was available via the diagnostic images, and no patient required a face-to-face follow-up because the doctors couldn't make a decision based on the diagnostics. In addition, 42% of patients were discharged back to referrers for ongoing monitoring and follow-up. The benefits to the patient is that the overdue review patients received a timely review appointment than if waited face-to-face consultation. However, it should be noted that the backlog was excavated by COVID-19 and the restrictions placed on review bookings. The hybrid telehealth consultation took significantly less time to complete than a traditional face-to-face consultation, and taking a combined average of 59 minutes. This is almost 2 hours less time than the average time spent in clinics when attending face-to-face. Looking at our feedback that we obtained, so the patient experience satisfaction survey was conducted over phone and on an average of 10 days after their telehealth consultation. And overall, the feedback was quite positive. 100% of patients found telehealth appointments convenient or very convenient, and the reasons included being able to stay home during COVID-19, not having to take time off work, and not waiting a long time in the waiting area. 70% agreed or strongly agreed that the care received during the telehealth consultation was as good as a face-to-face consultation, and they had opportunity to ask questions, and these were answered to their satisfaction. 90% were very satisfied with the telehealth experience, and 90% said they would like the option of a telehealth appointment in the future. However, there was a preference for the use of phone rather than video due to it being easier and more convenient. And feedback from the doctors included looking at the pre-implementation, doctors felt that they were confident in using telehealth despite not receiving any formal training previously. However, telehealth only consisted of less than 5% of their usual clinical workload. And their previous experience with telehealth was entirely from using the phone. However, they did have some concerns about not seeing the patient face-to-face and not identifying any incidental findings that they wouldn't pick up if they didn't see the patient. Post-implementation, the clinicians understood the benefits of the telehealth, and they were pleasantly surprised at the ease of the pathway and the ease of seeing the patient, and also the potential to be used for other cohorts of patients. So this could potentially include longer-term follow-ups that don't need to be seen face-to-face. Recommendations by the doctors for improvements in the pathway were noted, including a testing of visual acuity when the patients attend for the diagnostic test would also give a better indication to the doctor in regards if there's any impact to their vision. So looking at the lessons learned, the data extraction and problem analysis to be undertaken prior to defining the scope of the project would be quite helpful, just to clarify the suitable patients for the telehealth pathway, because this initially did delay our initial project phases. And what was really critical was the key stakeholder engagement in the early phases of the project, just to ensure that buy-in and support to ensure the delivery of the project, because if you don't have that buy-in, it can really delay the process and jeopardise the objectives being met of the project. So we also suggest the promotion of a test call offer to be used more often for patients to reduce potential technical difficulties. All patients were offered a test call, however, it was only accepted by one patient, and we feel that if more patients had the test call, then we would have less technical difficulties on the day of the consultation. The telehealth super user was also very helpful in supporting the doctors' buy-in initially, and also to ensure the process ran smoothly and that felt supported. So that was also a good thing. In terms of the future direction, there is certainly a potential role for ongoing telehealth care in the ocular oncology clinic. However, it's really dependent on our ability to identify suitable patients based on their diagnosis. And in order to support this, there is a development of a diagnosis-based database to be able to identify suitable patients. And this is a work in progress and will be supported by a newly appointed database manager. And ongoing work at the moment to receive electronic diagnostic images from our external community referrers, and this will really facilitate the screening of new choroidal naevus referrals and to really identify patients who could be managed in the community or that really need our tertiary care. And we're also considering potential expansion of the hybrid video telehealth pathway for long-term follow-ups, so patients who need to be seen up to a 5-year period annually, particularly patients post-plaque treatment, and also review of new patients after initial face-to-face baseline consultation, for example, if for choroidal naevus. So overall, this project demonstrated that telehealth is a good opportunity for certain groups of patients within the ocular oncology clinic and to enable the same site by saving time. Thank you. Look forward to answering any of your questions. Thanks.